Well, thank you for joining us. We're from Motion Picture Television Fund. This is the camera right here. We're Motion Picture Television Fund. We're a nonprofit that serves the entertainment industry community. And we serve people, whether it's, everybody thinks we're serving George Clooney, but it's, you know, the actors, the directors, the writers, but most of our people are the people behind the camera, costumers, drivers, caterers, all different things. So we have a large body of programs that we offer to entertainment industry folks, but it's also important to us to provide community education. And you know, if you guys after this talk have questions or need resources, Angela and I are available to talk that out. But today we wanted to talk about the importance of patient advocacy and people that are going through cancer having a voice in their treatment. And part of that often is using palliative care services, which are it's a scary word to some people, but we're gonna kind of talk that out and hopefully it'll make sense. And you'll find that really we wanna partner with you and help people have the voice and the best services and support they can have. So I'm Anne and
hi, my name is Angela. I'm the palliative care nurse at MPTF. Thank you again for allowing us to be here. It's really, palliative care is a passion for us. And like Anne said, it can be a scary word, but we hope to demystify that.
Can you hear it? Can everybody get
Yes, I can. Can everybody hear this at home okay?
Guess so.
So we're going to talk about you are a person, not just a patient, and it's about reclaiming your power in healthcare. You're not just a disease. I like to throw that in there as well, because we're more than that. You're not just a patient, you're a whole person. You have a story, you have values, you have loved ones, you have hopes of how your life's going to be lived. And even when you have cancer, those still hold true. So we're here today to talk about living with cancer and how to stay in control and preserve that sense of self. We also want to introduce or perhaps reframe how palliative care fits into that journey. As a palliative care team, our goal is to focus on quality of life and to, like Anne said, partner with you and your loved ones throughout your experience. Whether it's pursuing treatments, whether you're looking at comfort, we really want to walk alongside so you guys are not going through this alone. So you are a bridge. This is actually a really good video explaining how palliative care fits in to someone who's diagnosed with a serious illness. Please, hopefully this works.
Are you a registered nurse who wants to swap out your 12-hour soul-crushing shifts for more meaningful work? Want to know?
We can't really see the screen. Could you tilt it a little towards the camera, please?
Or a bridge. It's true.
Yeah,
When you're healthy,
that's
when the
good.
bridge
I
is
think
sound,
that's
You got it?
you can handle
Yeah,
anything.
because if we turn
Cars,
it to my
trucks,
left,
trains, all the bumps of life. No
Oh,
problem.
okay.
You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
always gonna mess this up, man. Exit full screen.
Hi, my name is Steve Panalak. I'm a professor of clinical medicine at UCSF and the director of the Palliative.
Leave it to
Care
Angela to.
Program. Let me start
He can just
talking to you
speak
about
for it.
palliative care by giving you
We do
really
like-
the single most important takeaway.
So you are a bridge and you're the one navigating between your medical care, between your personal life, your emotional worlds. You're carrying so much in reference to the video we just saw. And our role in palliative care is really to help strengthen that bridge. The cancer journey is so much more than treatments and scans. Yet often the medical care focuses on just the physical aspects. When you go into a doctor's office, you're talking about test results and interventions and procedures. Appointments can often be rushed, and it leaves a lot of the human experience out of it. And as we know, cancer is not just physical, it's a very emotional process. It can stir profound questions about identity, purpose, and meaning. It can stir some confusion and some fear. Can I keep working? How do I pay my bills? How will my relationships be affected? How do I tell my kids? We have to face all of these questions, and yet the medical system kind of leaves you alone with that. There's nobody to walk alongside and hold your hand through that. And that can be very challenging. And that's really where palliative care comes in. We look at more than just the disease. We're looking at the person going through that and trying to be there for them in that capacity. This is the medical system. Let's be honest, it's fragmented, overwhelming, it's siloed. How many times do you have multiple, physicians or specialties meeting with you? They're not talking to each other. Appointments are 30 minutes, but maybe you get 15 minutes with a doctor. You have questions that you need answers. You can barely have time to go over that, let alone process how you're feeling. And although the doctors have good intentions, sometimes this can leave patients feeling overwhelmed, emotionally isolated. And this is why we advocate for a system that really kind of looks at the whole person. Because when you get this, you leave so much of what's needed is left, all those questions are left unanswered. So this is what we mostly face as when we're dealing with cancer, a disease-centered approach where a patient is defined by the disease. Oh, that person has breast cancer, they have prostate cancer. Then it's further defined by your stage. It often leaves us feeling isolated. It's not looking at the person. We use standardized treatments and protocols, and it's a one-size-fits-all model. And it doesn't anticipate what our needs are, what our goals, what our values, what we want out of our care. So this is what most cancer patients have to face, the disease-centered care. What palliative care looks at is person-centered care. Our care begins with who you are, not just what diagnosis you have. It's about listening to your goals, respecting your values, shaping care that fits what matters to you most. For one person, a priority might be staying at home for as long as they can. For another, it might be traveling, spending time with family. We know it's not a one-size-fits-all. No two lives are the same. So palliative care makes sure that your care plan reflects your life plan. So what is palliative care? It's a specialized medical care for people living with a serious illness such as cancer. Our goal is to improve quality of life. We look at the physical aspects, the emotional aspects, spiritual aspects. We want to help you live well while you're living with your disease, while you're getting treatment. We work together with your doctors to manage symptoms like pain, fatigue, shortness of breath. We help you make informed decisions that align with your values. We guide you through advanced care planning, making sure your wishes are known, documented, and followed. And right here where we see cancer care is not a straight line. It involves different phases. and your needs may shift along the way. This bow tie model helps illustrate how palliative care can fit that full spectrum of the cancer experience. On the left side of the model, where you have the diagnosis, we would have the parts where we're getting medical treatment, the radiation, chemotherapy, surgery. And it's focused on cure, it's focused on controlling the cancer. Whereas on the other end of the spectrum, we have survivorship, we have maybe treatment is either in remission or perhaps treatment's not working anymore and we're more towards quality and maybe hospice and end of life. And as you can see, palliative care is in the middle and it's intertwined throughout the disease process, supporting maybe a little bit in the beginning, heavy in the middle, and then as we transition over here, supporting through survivorship or through hospice. At the heart of palliative care is quality of life, and that quality of life is defined by you. Like I said, there's no two people that are the same. We all have different meanings and values and things that matter to us. So it's not always about choosing treatment or comfort. They're not mutually exclusive. You can have both. We're here to provide support so that while you're going through treatment, you still have quality of life and you're still comfortable. And it's worth repeating, palliative care doesn't take the place of your regular physicians. We don't take the place of an oncologist or your primary care physician. We're supportive care. While they're sitting there focusing on the cancer, we're focusing on you and what matters to you. And we do this, we look at better symptom management. Our physician, nurse, we are trained to deal with complex symptoms like fatigue and pain and shortness of breath, either from the disease itself or from the treatment. And because we focus on better symptom management, we actually reduce the time spent at ER visits at the hospital because you're more comfortable and you just have better quality care. And then because our team specifically, we have a chaplain and a social worker, we're able to work with the psychological and the spiritual needs of our cancer patients, the fear, the grief, the existential questions that come along with that. Whereas care might ask, what's the matter with you? We ask, what matters to you? And that's really our goal.
Drive for me. So what do we focus on? We focus on improving quality of life because, like Angela said, that's really like, what is the purpose of us doing treatment if we're just, sitting in a bed in severe pain? It's really about what matters to you, what's important, so you can live your life as whatever stage of your cancer diagnosis. And by the way, we're talking about cancer, but palliative care is for a variety of life-altering illnesses. We work with a lot of people that have cancer, but they're the caregiver of a mom who has dementia or something like that. And they would be appropriate, if they didn't want it for themselves, they could get palliative care for their loved one we have patients with COPD or other high kidney disease or other high burdens. So, side note. So we work on quality of life. We work on advanced healthcare planning. This is really important. And people will say to us, don't talk about that. Like, I'm doing fine. I'm in the beginning stage. Like, don't jinx it. Don't jinx me. And we really want to talk about the future because we want to do it when we're not in a crisis. I like to say we want to strike when the iron is cold, that we don't want to be in a heated emotional situation where it's too hard to make decisions. So one of the most important things, if nothing else, for us to know is who would be your decision maker, who would speak for you if you had to have surgery or if you were experiencing complications where you couldn't speak for yourself. So that's an important part of palliative care, is sitting down, talking about those things, what types of treatment. For me, realizing with COVID, we went from sort of this society that felt we were gonna, we're gonna live forever, we're getting older and older, and then COVID hit, and it's like your 20-year-old neighbor's sick and in the hospital, or So we never know, and so really having those plans are important. And it can be hard to talk about, and that's why palliative care teams can help kind of make it a little bit easier. And like Angela said, we focus on pain and symptom management. The Dame Cicely Saunders is the founder of the modern hospice movement, and she talked about what's called total pain. And that's where we have the mind-body connection, it's there. And so you may come in, we have patients that come in and say, I'm having severe physical pain. And as we're talking, they're like, I feel better, like the pain isn't that bad anymore. And we didn't, shove a piece of, pill or anything in them, but it was just talking and feeling seen and heard and be able to process that stuff. The pain feels differently. But when you're isolated, or we get into that loop of negative thinking, like I'm always going to feel this way, it's never going to get better, then the pain is going to get worse. So when we look at total pain, we're looking at the physical because that is essential. We are looking at the spiritual or existential, like why is this happening? How do I make sense of it? If I have a specific faith, how do I reconnect to that? If I have spirituality but not an organized religion, how do I tap into those things? And then the psychological, emotional, social part of it, where what are the stressors that are making me worry so much that my body is hurting? If you think about when you're highly anxious, your stomach hurts. If you're feeling a headache and you can't get off the couch, you're going to get depressed. It's all connected. So palliative care can help look at that. So we're not just saying, well, are you depressed? Here's an antidepressant. Well, you're having pain, let's give you an opiate medication, or, go to church if you have a question like that. It's like, it's all integrated. And what we find in our visits is a lot of times people will come in for one thing and they'll start talking about something else. So having that holistic model is really addressing that. Because like Angela said, I remember my kids, one of them got sick and I was really stressed with work. And I go into the pediatrician and I'm like, I can't handle this. Like, I'm a working mom. And I start crying and the doctor's, and he just like walked out of the room. He comes back and I'm crying and he's like, God. So a lot of doctors don't want to deal with the emotion part, especially with the serious illness. They're with cancer and things, they're very analytical, and we're like, no, let's talk about the softer side, because that's the side that's driving us. And then also the medical system navigation. I know a lot of times when you'll see a palliative care doctor, they might not have the full team, but places like WeSpark, I think, is sort of that sort of complementary part of palliative care, in terms of like with our program or WeSpark, there's medical navigation. Like if you have a question, you have neuropathy, who's the best person to treat that? Or, helping link you to different resources. And then the caregiver and bereavement part is really important. My husband has metastatic prostate cancer, and it's been really hard. And as much as I'm a psychotherapist, I'm a social worker, I think emotions are important. But as a caregiver, I'm like, no, this is a physical disease. But then the whole family's bottoming out, like they're, really sad, thinking about what's going to happen to my husband or my dad. And so really looking at the caregivers need emotional support, because they're oftentimes the one that's holding up the family. If, the person with cancer is going to treatment and driving all over town and, sick or in bed, you want to make sure that the caregiver, the family support is bolstered up to be able to take some of that weight. So coordinated whole person care. And I'm going to kind of talk about a case where the doctor and the nurse manage the physical symptoms. We all kind of have a crossover, because we find that, again, if one of us isn't there, the others of us have enough knowledge to be able to kind of process things out or give resources. But generally the physician and the nurse are managing the physical symptoms, discussing prognosis, which isn't always easy. It's really important for people to tell us what their preference is with communication. Some people say, I don't want to hear anything negative. I want to stay focused on the present. Other people say, tell me the worst case scenario so I can plan for things if things change. The social worker provides patients accessing resources. So a lot of times I have people asking, how do I get caregiver support? What are financial grants out there? You know, how do I get psychotherapy? Things like that. And then the chaplain discusses the spiritual and existential suffering. Why did this happen? I feel like I'm to fault with this, or whatever the tapes in our head that, you know, we sort of go back to that earlier part of ourselves questioning things. So palliative care is not opposed to aggressive and life prolonging care. A lot of times people kind of get jinxed by us when we say palliative care is, you know, getting referred, because they're like, we're not dying, I'm not on hospice, I don't want to do that. And like Angela showed, that bow tie model, that palliative care is from the beginning stage of diagnosis through the end of treatment or as you transition to hospice. If you think of it sort of like an umbrella, palliative care covers new diagnosis all the way to hospice. Hospice is a tiny part of that, usually in the when a person is given a prognosis of 6 months or less to live. But most of the care that palliative care provides is in the new diagnosis or that middle part where you're going through treatment and have a lot of different symptoms. So we're not only reserved for the end of life, we really want to get to people sooner, the better, because we can help lower the distress and increase quality of life, and help with communication so that your doctors, your treatment team knows what's important to you. So we're not doing all these interventions that maybe don't align with what your goals are. So just to give you a couple examples with my husband, when he first got his diagnosis, it was metastatic, but he was pretty controlled. And so because I'm in the biz, I referred him to our doctor, and the doctor pretty much didn't do a lot other than to just get to know him and kind of have a path. And then as his symptoms got worse, he's treating all the different parts. He had a lot of radiation damage, so he was having bowel issues. So that became a big part of the treatment. And then as we're facing like sort of forks in the road, do we do chemo? Do we do this new treatment? Do we do a clinical trial? Do we kind of coast with the medication? What do we do? It's very overwhelming for people when, you know, we're not, probably most of us aren't doctors. So it's like, how do you make sense of that? And a lot of times palliative care is a place to let's sit and talk about it and see, you know, what makes sense to you. And like Angela said, a lot of times you'll see the doctor, they'll give you the 15 minutes, like, we'll go read about this or, you know, research that. But it's really, sometimes you just need sort of a sounding board to talk it out, and that's where we can help. Oh, the other one I was gonna mention. So we had a patient that was newly diagnosed with breast cancer. She was larger than the gowns in the radiation program. So she wasn't fitting them correctly, and she had a lot of body shame. It was really embarrassing. And so it was causing a lot of trauma. She felt like, you know, exposed, and that she just didn't feel comfortable. So with our team, she also was having a lot of nausea. She was having neuropathy, different issues. And so worried about those things. And then she was questioning, why is this happening to me? Like, this is just the old stuff that it's always, you know, stacked up on me, that I've had all these problems throughout my life, and it's one more thing. So as the palliative care social worker, I contacted the radiation center and talked to the staff there and said, you know, we have this issue. Are there larger gowns that could be provided so that it's less, you know, impactful for her, and coordinating care and communication to make it more comfortable there. With the chaplain, he worked with her on, you know, talking about those old messages and what strengths has she overcome, what has she used to adapt now in her adult life, and how do you get back to that space, whether it was, you know, going back to church or temple, or if it was doing other meditation practices, or you know, validating herself. And then the nurse and the doctor worked on the nausea, the different physical symptoms, medication to help with the neuropathy, especially in the context of the work she was doing to make sure that her symptoms were managed within the time frame, so she wasn't overly drowsy during work times, things like that. So she graduated and we said, we're here if you need us. And a couple of years later, she came back with new symptoms, new issues, and the doctor and the nurse were able to explain the terminology, to break down. Sometimes doctors talk in their own language and some of it doesn't make sense. There's not time, or sometimes I'm like, I'm too embarrassed to ask the questions. And that's where our team is like, there's no stupid question, let's talk about what this really means. And just providing the time to process. We worked on advanced healthcare directives, and then also talking about what was dignity to her, what was meaning to her, and how she wanted to prepare for the next phase of her journey. So just processing that. So the opportunities for palliative care is, I don't think anyone is seeing how much I'm suffering. And that's a big one, because oftentimes families get burned out. We don't want to talk to friends. And so we just kind of hole up in ourselves, but we're silently in pain, and we provide a space to talk about it. No one's actually managing my pain. I'm sure Angela could attest to all the Friday night calls that she gets Friday afternoon. Like, I need a refill. My doctor didn't do A, B, and C. And having the palliative care team or people that are struggling with getting the right types of pain medications, because doctors are saying you don't really need that, or we don't want you to be med seeking or something like that. So the palliative care doctor is comfortable with prescribing the right types of medication and understanding what cancer pain really means. My quality of life is a big priority for me. It's easy to be on the treatment roller coaster or the train where it's like, oh, if we do one, like my husband, we'll do one more thing, and then we'll do this, and then we'll do that. And it's like, I don't know, let's slow down. Like, do I want all this? Or what's reasonable for my situation? We have patients that are 90 years old being told to do, very aggressive treatments, when she's like, maybe I just kind of want to slow it down and work on the cancer, but also be comfortable. So be with my grandkids. So what's a balance there? I don't think the doctors actually know what I want. And that's where what Angela was talking about, the siloed communication. When doctors aren't communicating with each other, it's hard to know, it's hard to have a voice, because you can go to your primary care and say, this is important to me, but it doesn't mean they go and talk to the oncologist. And at least for me, I forget what my questions are. As soon as I get in the car, I remember, oh, I should have asked that, or I should have done that. And if I go talk to a different doctor, it's totally out of context. So we can help talk about what you want. And then I feel like none of my doctors are talking to each other. A lot of times our physician or Angela will get in touch with different ones of our doctors. Like, they'll call the primary and say, hey, we're working on this. We're working on the advanced care planning, or we're managing the pain. This is what we're doing, so that we're not duplicating, or there's no misunderstandings. So palliative care matters. Studies are showing that palliative care improves patient mood, quality of life, that it reduces their pain, overall increases patient satisfaction with care overall. We kind of have a joke with our team that about 70% of our first-time patients will cry. And so we sort of feel like that's a good success rate, that people can let down their guard and really be able to talk about things that they want to say, and providing a vulnerable space for them. It also decreases caregiver burnout. We are really find that a lot of our caregivers, maybe not so much in the early parts of treatment, but as the disease progresses, the care needs increase, and that's where we really want to help the caregivers feel strong enough to make it a better quality of life. Because if I'm the caregiver and I'm burned out and snapping at my loved one, then they're not going to feel good, and they're not going to want to come to me. So then their symptoms worsen, and then Angela gets the call like, help. And then it also helps improve the bereavement process, because not only are families bereaving as a person is nearing the end of their life, but the patient themselves are, grieving, even in the beginning or the middle of treatment. Cancer changes how we see ourselves. And so being able to talk about grief and to process through grief when at the end of a person's life, the patient has more resolution, hopefully, and the family has more of an understanding that they've kind of been grieving all along, so that it's not quite as shocking or painful to them. So, as I said, advanced care planning is very important. There's documents. People think you have to go to a lawyer. You don't have to go to a lawyer for an advanced healthcare directive. You can get them online. If you can Google it. If you have a question, you can email me. There's a lot of medical systems like UCLA or Cedars or Kaiser have their own version. And it basically has a question. It basically is getting to know your history, what's important to you. And then you have two witnesses that are not financially going to benefit from your death, that are not immediate relatives. You are the person that signed it, or you could get a notary, which, $20 or something like that. And then that becomes a legal document. So who is eligible? Anyone with a serious illness or life-altering illness that without life-sustaining treatments could result in a worsening condition. So with Motion Picture Television Fund, we have a pretty open program where a lot of our patients are on service for 5-10 years even. Some of the programs will say, well, it's sort of like if you're in the middle stage, not necessarily the beginning, but as you're having more symptom burden. Not, it's pretty it's different for every health system. So if you're finding there's any pushback, like, no, you don't need palliative care, just dig a little deeper and really kind of push to get information, and then talking to the palliative care programs out there, you can decide, they can help show you how they could benefit your care. So illnesses that qualify: cancer, heart disease, lung disease, kidney, liver, Huntington's disease, ALS. ALS, I don't know if any of you know anyone, but that is a very important one because there's specific markers as you're going along. So you really want to plan and prepare for the transitions. Multiple sclerosis, Parkinson's, HIV, traumatic brain injury, all different types of dementia and congenital, and how do you say that? Anomalies. So a lot of different types. Basically, if you're running into a place where you have a serious illness that's life-altering, not something like chronic pain where you've had a lot of physical injuries, that's better dealt with by pain management. But if you have a life-limiting, life-altering condition where there's the pain or the physical symptoms, there's the emotional distress, the existential or spiritual, that's where we're looking at sort of that integrated approach where palliative care can be helpful. So how to enroll? Ask your physician or treating provider. Most of the time they're open to at least putting a referral so you can get more information. Sometimes doctors see it as end of life. We just did a training with one of our primary care groups, and we said, what do you know about palliative care? They've been referring forever to us. What do you know about palliative care? It means that the person's dying. And it's like, oh God. So it's like, there's always this confusion. And so sometimes it's pushing back on your primary care or your oncologist and saying, look, I need this and I want to get more information. You can oftentimes have to educate them, and then reach out to community partners. We work with UCLA, but you go to the next one, there's a lot of different programs. Oh, can you go to the next one, please? Yeah, so UCLA, USC, Cedars, City of Hope, Providence, Kaiser, and these are all outpatient programs, and then there's a lot of in-home palliative care, especially if you're finding it hard to get out to appointments. There's a lot of programs sometimes connected to hospice. So it's sort of like a middle stage type of treatment. If you are moving towards the hospice direction, it's a transition, but a lot of programs have the palliative care part. So going back, sorry. So Motion Picture Television Fund Palliative Care like I said, we're a nonprofit, we're a free service to industry members, and we partner with UCLA and other health organizations. So if you know anyone that's in the industry that could benefit from the program, we work with patients and their industry members and their parents, sometimes their children. So we are a resource, but we wanted to tell you about our services, but also know that there's other resources out there too that, you know, just because we're working on one agency doesn't mean that we can't refer you to other equally as helpful programs. I think that's it. So if you have questions, we'll definitely open it up, and here's our contact information that I don't know if you'll have this, or you could contact Lee Spark to get our information.
Yeah, we're gonna actually email the slides
Great.
to everybody who's on the list. I think everybody at home unfortunately is having a hard time seeing the screen. So just so we're clear, we are gonna email that out to everyone. So they'll
Right.
have all of your information, and we have contact information for all the other organizations you were talking about.
Great. Does anyone have any questions?
See, someone wants to know, do we have to be in the industry?
Yeah, for our program you do, but again, there's a lot, I know Cedars, sometimes people are afraid of the word palliative care, so some programs have switched names, so Cedars has the supportive care team. So really asking whatever your health organization is, they have palliative care, it's just finding out how to access it.
And can they reach out to you
Yeah.
for additional information if they're not
Absolutely.
with motion picture?
Absolutely,
Okay.
yeah.
Okay, so who pays? Medicare, Medi-Cal? How much out of pocket is typical?
So that's kind of a interesting question, and it's a very good question. With our program, UCLA is paid for by the medical insurance. Most programs have funding through the insurance for the medical provider. The rest of the stuff is philanthropy. What people find is that palliative care is such a good resource and support that it lessens the burden on, not that anybody's a burden, but just lessens the intensity of the calls to the oncologist or to the medical, system. So they find that we're a good outlet to take care of the needs of the person. So generally, organizations will feel like it's a good investment to have a palliative care program. So the providers pay for your insurance, and then the rest of the team is funded by the organization. So it's free to industry, free to patients. The way it works with in-home palliative care, usually hospice is paid for by the medical system. Medicare sets the standard, but insurances, Medicaid, Medi-Cal, all different insurances pay for it. But what they find is we haven't over, the federal government hasn't established a payer plan to fund palliative care. So what hospice programs will do is they figure it's kind of a loss leader, that we know people will eventually move to hospice. It might be years, but we will create a palliative care program because it makes sense to already have that relationship, already be engaged. And some of the ones in this area at least have providers on their team. So for example, Skirball or Providence, they have palliative care programs that the person is seen by the physician or the nurse practitioner regularly. The insurance covers that, and if there's a social worker or nursing issue, then that organization takes, the cut. They don't charge, they just provide that additional service.
Thank you. What credentials should one ask for when seeking providers?
Well, we are all certified in palliative care. Doctors are certified in palliative care, so I think that's the basic. Do you have?
So pretty much if you're doctor or if you're
It's
Yeah.
a, yeah,
It's
it's
a specialty. A lot of pain management physicians will have some expertise in that, and they may transition over. But I think now, because palliative care is relatively new, but now you're getting more physicians that is their specialty.
Fantastic, thank you.
It's also just a side note to that, palliative care is available in the hospital too. And we find that that's really important because you're in the hospital, you're making decisions, you're wanting to go home or figure things out. And a lot of times people will call us with confusion. And always, if you feel like this is a complex hospitalization, ask for a palliative care consult, and most hospitals now have that.
Does anybody here have any questions? And also at home, like if you have more questions, please feel free to put them in the chat.
Now, I would just like to say that palliative care has been so great for me. I've been having it at Cedars, Dr. Arash Asher.
Yeah.
But it's, again, you have cancer, you're gonna take off both your breasts, wake up, okay, see ya in a week.
Yeah.
Okay, see you in 6 months. There was nothing. A gal came in on the visit, the week checkup after the surgery. She says, I'm like with the therapy part, whatever it was, and there was nothing. I mean, there was nothing. I remember calling and there was nothing. And I was just livid. And then I was fortunate to already know Dr. Asher because it wasn't my first rodeo with breast cancer. So, but it's been wonderful, very integrative. Also, it's not just medical, it's, you know, vitamins and exercise and doing for yourself. That's, for me, that was the goal, is to just get back to know, you know.
Get back who you are as a person.
Yeah, not to lose yourself in a wallow or, you know. So I think it's a wonderful tool, or it's vital.
Yeah. And I think you make a good point, like eventually your physical scars are gonna heal and you're gonna physically feel better, but it's the fallout of this was a very traumatic or a very impactful experience, and all the emotions and all that stuff doesn't happen in the moment because you're doing what you have to do to get through, but then you kind of, all that stuff comes up and you want a safe place to talk about it.
Thank you for sharing that. That's, and I think also I wanted, you bring up a really good point, is when we get to know who you are and what matters to you, it's not always about prescribing an opioid. Sometimes it's about exercise, sometimes it's about connection, sometimes it's about getting some vitamin D. It's what kind of care do you want, and how do we fit our interventions to align with that? I think that's why when we talk about not losing yourself, it's understanding that who you are and what matters that really, you know, helps out. And when Ann says we have a 70 to 80% cry rate, I'm not kidding. And it's really, it usually happens like this: how are you? And, you know, because no one sets the time to say, how are you? Because they just want to know, how are you, how are you feeling physically, or where is the, it's not that. It's
What's your
how
vitals?
are you? Yes, what are your vitals? You're vital, and we want to know how are you and what matters.
So I just want to find out, so if I go to my oncologist and I can ask if they have a palliative care program, he could give me that information right then and there.
Yeah,
Okay.
he can give you a referral to a palliative care physician.
Okay.
I think most hospitals, or I'm sorry, medical systems now, I'm pretty sure most of it, there's not a lot of small, you know, private business oncology, I don't think. So most of the medical systems have palliative care programs. But again, you can always reach out to us and we'll help you navigate that.
I encourage, even if, you know, Ann and I do the intakes when we get a referral from a patient from UCLA, and there is even resistance in that sometimes. And I always say, just sit down, just give us one shot, meet us one time. And if you absolutely say this is not for me, then write it off, put it in your book, maybe you'll need it later. But if, imagine the benefit, if it does work for you, like it can be very purposeful and
Yeah, I
helpful.
find myself talking to other women who are newly diagnosed and there's often a real block.
Yeah.
A real block to getting help or getting outside of your square box for thinking, or just listening to that doctor who's not up on the latest things, that second opinion,
Right.
mortality care, whatever it is. It's interesting the resistance that
Yeah. Change can be hard, and for some physicians, and Ann and I both worked at a hospital before, and for some physicians, when they have to ask for outside help, that might be a sign of failure for them. Like, what am I not providing? And they just don't understand. They're doing a great job at treating the disease, but their expertise is not in dealing with all the other stuff.
The quality of
Yeah.
life.
And it doesn't mean like their intentions are bad, it's just that's what they know, and that's.
First of all, thank you so much. That was really interesting and informative. I love it. I mean, what you talked about today is WeSpark's mission.
Yeah.
To enhance the experience and minimize the effects of the emotional and the physical effects.
Yeah. Yeah, I think like at Motion Picture, we have a really robust program, but a lot of programs don't have that other, I call it like, that old, the softer side of Sears,
Yeah, sure.
like a lot of programs don't have the social work, the chaplaincy and things. And that's where I think, WeSpark to me is palliative care. It's the other side of the hardcore medicine. And so whether it's with a program that has, like Cedars has full integration, a lot of the stuff we refer to WeSpark all the time because we don't have, the Reiki, the art, the support groups. There's so much of that WeSpark is coming from a really soulful perspective. And so I feel like you guys are part of the palliative care team.
for sure.
Well, thank you for having us. It was
Yeah,
really nice to
I
meet you.
have another question on here. Someone wants to know, is care normal for open heart surgery patients with their team?
You mean for palliative care?
I think so. Whoever asked that question, if you want to unmute.
Yes.
Can you explain a little bit more?
Well, I've got cancer, but I also have a heart condition. And one of the things, because I'm completely by myself, is, they're telling me I need open heart surgery, but there's no way I can handle it. I mean, it's a long surgery recovery. There's a lot of mortality, morbidity issues with it. And I am getting older and it's getting worse and I'm getting more and more tired. So
I think palliative care would be an excellent resource for you because as people get more illness or, more complications, you need somebody in your pocket. You need somebody that cares about you and that can also discuss those, you have practical issues. Who's going to care for me after I get the surgery? Who's going to pick me up? Or do I need to go to rehab? Or whatever those questions are. Again, it's like your cardiologist, your oncologist, they might not be connecting or thinking about what does this look like after the procedures. And so having palliative care, I would definitely recommend that you get them on board to be helpful, especially before you get the treatment, before you get the surgery, because you really want to plan and be prepared.
yeah, thank you.
Yeah.
So if anybody else has any other questions, now's the time. And also here in person, if you guys want to know anything, please feel free.
Well, thank you for having us.
Thank you so much
Really
for
nice to see
coming.
you all.
Thank
Yes.
you.
Thank you. That's really nice.
Awesome.
Thank you.
Thank you very much.
I was curious about how does a doctor become a palliative? And I do have a question. As opposed to an internist.
Your husband? Yeah, I don't know how, I don't know how our doctor practice. Yeah, absolutely. But it is a newer field.
Yeah, we're,
Like I said,
the
it's a
industry
calling.
member is your husband and then
The way
family,
different approach,
parents,
it's a way-
children,
it's a different
you all
connection.
qualify. So if you want to give us a call, we can have you. And then a lot of times, we work with the UCLA physician, but like if you really like your seniors program, then we would work with him. So the rest of us would be available to you.
Right, we get your ortho surgeons who just want to talk to
Seniors.
Yeah,
I used to
yeah.
see doctors and all that.
Yeah, absolutely. If you wanna take my phone number.